Welcome to another EduMed video, and in this video we'll be talking about how to set the I to E ratio, or the inspired to expired ratio. And this is really a corollary of the respiratory rate and the inspired time that you set on a ventilator. So it's worth thinking about why you want to set the respiratory rate and the TI, and that comes down to clearance of CO2. As we discussed in all the other videos, clearance of CO2 relies purely on two things in conventional ventilation. The first thing is the minute ventilation, and the second thing is alveolar perfusion. We won't talk about alveolar perfusion in too much detail here, but suffice to say you must have each alveolus being supplied by deoxygenated blood, which allows the CO2 to be cleared from it and for oxygen to be moved into it in order to have adequate and appropriate ventilation. In terms of minute ventilation, it is a function of two things. The first is the tidal volume, and the second is the respiratory rate. Now, for the most part, tidal volume is set already. With lung protective ventilation, we know that we need to give between 6 and 8 mils per kilo. So for an 80 kilo patient, we're looking at about 480 mils. We don't go above this because we know that there's good evidence that if you over-distend alveoli beyond this, you can cause damage and fracturing of the normal alveolar wall and therefore increase inflammation and therefore increase damage to the lungs, prolonging ventilation further and potentially creating irrevocable damage to the lungs. So if the tidal volume is set and your CO2 is starting to rise, the only thing that you can do is increase the respiratory rate. But doing this can cause problems, and we'll go through this in a little bit of detail later in this talk. It's worth just thinking about increasing tidal volumes because you could go from 6 to 8 mils per kilo, but the problem with trying to increase the tidal volumes is that you are going to have to increase the pressure of the ventilator in order to be able to force that extra amount of air into the lungs. And if you increase your pressure, again, you can cause damage to the alveoli, something called barotrauma, where if you've got lots of pressure that the alveoli sees, similar to that of a balloon, they can pop or they can tear open. If they do that, then that again can cause inflammation and potentially pneumothoraces. So we tend not to go with a peak pressure above 30. And that's a peak in pressure mode of ventilation, or a plateau pressure is what we think about when we're talking about volume modes of ventilation. It's always worth just stopping and thinking about what you can set on a ventilator. And as I went through in all my other talks, it's really only 5 things that you set on a ventilator. They're not complicated machines to actually set up. And of these, the 2 things that we will be talking about are the respiratory rate and the TI, which is also known as the inspired time. Before we talk in more detail about inspired times and respiratory rates, it's worth just conceptualizing exactly what a ventilator does. When you switch on a ventilator, there's usually 3 graphs that turn up as a default. The first is the pressure time graph. And let's have a little think about this. So this is a volume control mode of ventilation. What that means is that we tell the ventilator, I want you to give 480 mils with each breath at a rate of 12. So if we follow the pressure time graph, what you see here is that you're in expiration during this point, and the pressure isn't 0 because you've set a PEEP, or positive end expiratory pressure. And then at the start of the breath, the pressure will just start to shoot up. Now the pressure is going to keep going up and up and up until you hit your 480 mils. And once you've hit that 480 mils set tidal volume, you're going to have an exhalation. And so the ventilator is going to release that pressure and it's going to come back to PEEP. And during all of this time here, this is all expiration. Then if you look at the volume time graph, here you can see there is expiration, then you get the start of your breath. And now the volume is slowly going to increase up as the pressure increases until your ventilator hits that set tidal volume of 480 mils. And at that point, the ventilator will release and the volume will come out. So slowly it'll be breathed out until it gets back to zero, i.e. the lung pressure has equalised that of the outside pressure from the ventilator, and all of the air has escaped. Now, when we look at the different curves that you see on a ventilator, I always teach that there should be 2 curves on the screen at all times. The pressure time and the volume time graph, I'm not actually that bothered about. Of course, when I'm doing complex ventilation, I want to see those, but for every single person, you must have 2 graphs on the screen at all times. The first is the end-tidal CO2 graph. The reason that's important for any patient with invasive ventilation, be that through an oral endotracheal tube or a tracheostomy, is that it is the only way that you can prove that that tube is in the trachea and not sitting elsewhere, that you haven't accidentally extubated. It is the most sensitive and the most accurate way of confirming the tube position. So tip number 1, always make sure that your end-tidal CO2 curve is visible at all times. The second one that I want all of you to have on at all times is the flow time graph. And we'll go through this in a little bit of detail now. Again, let's imagine your patient. They're expiring during this point, and then at this point, you started your breath. So you're going to get a rapid rise in the flow rate in litres per minute until you hit that maximum flow rate. And at this point, you're still getting air rushing into the lungs up until you hit this point here, where you've got 480 mils of gas in the lungs. Once you've hit that set tidal volume of 480, the ventilator is going to release and go into its expiratory phase. And so it's going to drop down, and you're going to get negative flow. And this means that you're going to get flow, instead of going into the lungs, it's going to come out of the lungs and into the ventilator. And that's what the negative flow is. And then this is the point that I want you to see. At this point, there is 0 flow. And if you look up at your volume time graph, that correlates to the point at which all of the volume that you've put into the lungs has come out. The pressures have equalized between the inside of the lung and the ventilator on the outside, and all of the volume has escaped. So everything that you've given has come out at this point here, where flow equals 0. It's a really important point. So, we talk about TIs, or inspired times, and expired times. What are they? Well, in this top graph, you can see exactly what it is. An inspired time is the amount of time that you allow the ventilator to achieve that tidal volume you want. So, for example, if it's 480 mils, we say we want 480 mils, and you've got a TI time of, let's say, 1 second to achieve that. So the ventilator has a whole second to slowly push air in. You can imagine that if you shorten this TI time, but you say you want 480 mils, but instead of going it over a second, I want you to give it over half a second, suddenly the ventilator has to push that much far harder. It's got to increase the pressure, so that pressure jumps up because it's trying to force the same volume of air, but in a shorter period of time. So by shortening your TI, you increase your peak pressures. By increasing your TI, you decrease your peak pressures. So really important, because do you remember we talked a little bit about pressure causing barotrauma if you go above between 25 and 30 centimeters of water peak pressure or plateau pressure, depending on which mode of ventilation you're in? Well, this is how you can adjust that, because don't forget, your tidal volumes are essentially set. You've calculated it at 6 mils per kilo. So let's do a little bit of maths, because we can set the TI, we can set the respiratory rate, but we need to know what our expired time is to be able to work out a ratio. So let's take a simple example. Let's set a TI of 1 second and a respiratory rate of 20. What would be your TE? And what would be your I to E ratio? If you want, you can pause the video at this point and work it out for yourself. I'll be honest, most intensive care ventilators actually give you an I/E ratio, so it'll do the calculation for you. But it's always worth just seeing what it is. So here you can see that you've got 20 breaths in a minute. And so if there are 20 breaths in 60 seconds, each breath has got to last 3 seconds. So this is your respiratory cycle. From inspiration to the next inspiration is 3 seconds. Now we've already set our TI time at 1 second. So if there's 1 second of that 3 seconds is in inspiration, by definition 3 minus 1 equals 2. You've got 2 seconds in expiration. So what's your I/E ratio? Well, if your TI is 1 second and your TE is 2 seconds, then you're going to have a 1:2 ratio. If, however, you increase your TI up to say 1.5 seconds, but you kept your respiratory rate at 20, what's going to happen to your I/E ratio? Now you've got 1.5 seconds in inspiration, so you've only got 1.5 seconds in expiration. 3 minus 1.5 is 1.5. So now your I/E ratio has gone from 1:2 to 1:1. So you can change your I/E ratio by changing your TI time. The other way that you can do it is by changing your respiratory rate. So for example, if you have a respiratory rate of only 10, that means each breath cycle, so the time between an inspiration to inspiration, has gone from 3 seconds to 6 seconds. So now your respiratory time is 6 seconds. If you've kept your TI time at only 1 second, 6 minus 1 is 5. That means you've got 5 seconds of expiration. If you drop your respiratory rate down to 10, but keep your TI at 1 second, you're going to have a 1:5 I/E ratio. So you can see how you can adjust it purely by changing either the TI or the respiratory rate. So whenever you change one or the other, be careful because you are changing the I/E ratio. And if you just turn up the respiratory rate on a patient, you can very quickly change your IE ratio quite significantly. So let's think a little bit about a common case that you can get. You're the ITU SHO or the registrar. You've just taken over a handover of a laparotomy patient they've kept intubated and the anaesthetist has brought over to the intensive care unit for 24-48 hours of stabilisation, intubation and ventilation. They've been transferred on their transfer ventilator, but then the anaesthetist suddenly gets called and has to run off to a cardiac arrest, and they ask you to put the patient on the ventilator. How do you approach this patient? Well, if you go back to my very first lecture, which was the basics of intensive care, and I go through the systematic approach in which you should come to every patient that you get on the intensive care, go through it from an ABC approach. Now, I'll only glance over this for this example because I really want to come onto the ventilator settings. But effectively, you look at the airway. You see, is the endotracheal tube in the right place? Is it the right length? Is there bilateral air entry? Is the cuff still up? Have a feel. Go to my video on endotracheal tubes and have a watch of that. It's really useful information that I haven't really found elsewhere, and no one really teaches you that stuff. So please do go and have a look at that video. I think it's really helpful to juniors starting off in intensive care, and actually even some seniors. Then think about your breathing. What's their fractional inspired oxygen concentration? Are they on 100%? Are they on 20%? It very much depends on how stable the patient is. What respiratory rate have they set it at? What pressures are they needing to get an appropriate tidal volume? Have they set it at a tidal volume of 480 and they're needing, say, 40 centimetres of water pressure to achieve that, i.e. they're overpressurizing the lungs? It's always worth looking at the anaesthetic charts, seeing when they were last paralysed. Often, most people will try to paralyse their patients before bringing them to intensive care, to stop them becoming desynchronous on a ventilator, and to stop them from coughing the tube out when they're moving the patient. And finally, how much PEEP are they on? All of these things will make a lot more sense if you watch the first few videos on my channel going through ventilators and going through how to manage basic ventilation. I have a video on the Oxylog 3000. Please go and have a look at it because it gives you a good introduction into the most common transfer ventilator that we use here in the UK. But essentially, the screen itself shows you most of what you need to know. It shows you the fractional inspired concentration of oxygen. It shows you how much PEEP they've set. And you can either see from the graph roughly how much pressure they are. So this is a 30 centimetre bar. So they're at about 25 to 28 centimetres of pressure to achieve that tidal volume that they've set. What is the tidal volume? Well, you can see here it's about 500 mils. And they've set a respiratory rate of only about 8 or 9 there. And so it's worth having a look at those settings, emulating them when you first put the patient on an intensive care ventilator, and then adjusting things as per the blood gases and the inputs and outputs that you get from the ventilator itself. So you put them on the ventilator, and this is the settings that you've done. So 40% oxygen, SATs are 95%, end tidal CO2 of 5.5. They're an 80 kilo patient, and you've set a tidal volume of 480. And this is the flow time graph that you're getting. Are you happy with this? Now let's have a little think about what's happening here. You've got the patient in expiration here, and then at this point the ventilator is saying give a breath. So the pressure is increasing. So you can see it's about 35, and then at this point you've hit the tidal volume, so the pressure then equalizes. So this is the plateau pressure. So we talk about plateau pressures, and that plateau pressure is 20. So that's the pressure that the ventilator, the lungs themselves are feeling. All of this extra pressure, this is the pressure that's needed to overcome resistance in the endotracheal tube and in the bronchi. So the alveolar don't see this 35-40 of pressure, they see the 20 of pressure that's here. So this patient's not being overpressurized, the pressure's all right. Now at this point, you get to the end of your TI, the TI is this time here, and then you get a release of that pressure. And this is all expiration here. And you've expired up until the next breath comes in. So on the face of it, that looks okay. You've got a pressure that's all right. You've got SATs that are okay, not on a lot of oxygen, and tidal's a little bit high. But what do you notice about the flow time graph? Let's think about it. You've got expiration, and then you suddenly got inspiration. So this is gas rushing into the lungs as they fill up, and you've hit that tidal volume that you've set of 480, and then the pressures equalize, and all of this is inspiration. And then at that point you get expiration. You've hit the end of your TI and you expire. Negative meaning expiration. And so you're expiring, and the rate is really quick to begin with. If you imagine releasing a balloon, it shoots off to begin with, and then as the balloon slowly empties, as the pressure reduces, the rate of flow decreases. So there's still gas in the lungs, it's still coming out. Oh, but what's happening here? Here, the ventilator has been told you've got to have a respiratory rate of, let's say, 20. We've got to the end of our 3 seconds of inspiration expiration time, and so the ventilator just gives another breath. But what is this? What does this mean? The lungs were emptying all the way through to here, but they weren't entirely empty because the flow hadn't come completely to zero. And so there was some gas still left in place. So this is the notion of gas trapping. If you have a look here, you can see that the pressure increases during inspiration, and then this is expiration, negative flow, and it's slowly releasing back to zero, but it never gets to zero. So there's always a little bit of gas left. And then the next breath comes in, and then the next breath comes in, and then the next breath comes in, and then the next breath comes in. So each time you're leaving, maybe only 50 mils of gas, but each time you're leaving that, so this is 50 mils of gas left. Then it becomes 100 mils of gas left. Then it becomes 150 mils of gas left. Then 200 mils of gas left. So you can see how you can get what we call breath stacking, or trapping of that gas inside the lungs more and more and more. What you want to do is you want to make sure that this flow time graph during expiration comes all the way back to zero. Because what does zero flow mean? It means that all of the gas that was in the lungs has escaped all the way back out into the ventilator. And so you're not getting that cumulative accumulation of gas. You're coming back to zero each time. And that's vital for making sure that the patients don't overpressurize, because if you continue on like this and you keep getting more and more gas accumulating in the lungs, you increase the pressure in the lungs. The ventilator needs to push harder to try and get the same amount of gas in, and eventually you will blow a pneumothorax. And this is why it's so vital to always have a flow time graph on, and to always look at this point here. During expiration, have they come back to zero? If they haven't, you need to extend their expiratory time to allow them to breathe. Can you see this is too short? It's not allowing it. But by extending it out, your expired time, you've now able to get more of the gas to come out. So you've extended your I to E ratio. And this is really what you do. So if you see that your flow time graph has not hit zero, you need to increase the I ratio. How do you increase the I ratio? Well, the first thing you could do is decrease your respiratory rate. We said before that if you've got a respiratory rate of 20, you've got a 3-second respiratory time between the inspirations. Now, if your TI is 1 second, that means that you've got 2 seconds for expiration. If you drop your respiratory rate from 20 down to 10 seconds, now you've got 6 seconds between each inspiration. If your TI remains at 1 second, now you've got a whole 5 seconds to allow all that gas to remove. And so you can just decrease the respiratory rate. But you've got to think to yourself, what's the problem with decreasing your respiratory rate? Well, just like we said right at the start of this talk, your carbon dioxide removal is dependent upon your minute ventilation. So if you decrease your respiratory rate, you are going to decrease your minute ventilation. So if you go from 20 breaths per minute down to 10 breaths per minute, you are halving the minute ventilation. Therefore, you're going to increase your CO2. So you've got to do that, but if you do that, accept the fact that you're going to have higher CO2s. So if CO2 clearance is a problem, you don't really want to do that. So what's your other option? Your other option is to decrease your TI. This is the amount of time that you're giving the ventilator to achieve the tidal volume that you've set. So if you have, say, a 20 breaths per minute and you had a TI of 1 second, that's a 1:2 ratio. Then, if you set that TI down to half a second, and you've got half a second for your inspiration time, your respiratory cycle still remains at 3 seconds, but 3 minus 0.5 is 2.5. So now, if you've got 0.5 to 2.5, your I to E ratio, if you get that to a 1, that's 1 to 3. You've extended your I to E ratio from 1 to 2 to 1 to 3. And that might be enough time to allow full expiration of the gas. But what's the problem with decreasing your TI? Now you're telling the ventilator to achieve the same volume of gas, but in a shorter period of time, well, it's going to have to use a higher pressure to drive that gas into the lungs. And by doing so, you're going to increase your plateau pressures or your PNs if you're in a pressure mode of ventilation. And that can lead to barotrauma if you're getting up into the 25 to 30 centimetre of water levels of pressure. So you get nothing for free, and usually it's a matter of managing both of them, reducing the respiratory rate a little bit, decreasing the TI a little bit, and trying to get the best of both worlds. And that's where the finesse of ventilation comes in. So what do I want you to take away from this talk? The first thing is always look at the flow loops. It is one of only 2 graphs that you should have on in every patient who's invasively ventilated. The first is the end tidal CO2 and the second is the flow loop. The only thing you really need to know about the flow loop for basic ventilation is look at the end of expiration. Has the flow gone down to 0? If it hasn't, you need to increase that I to E ratio and allow more time for expiration of that gas. If you increase the respiratory rate, you are going to have to increase your peak pressure because you're giving less time for the volume to be achieved if you're keeping the same I to E ratio. If you decrease your TI, then you get a longer I to E ratio, but again, you're going to increase your peak pressure. So you get nothing for free. You've always got to balance the 2 bits out. You've got to think about your barotrauma, and at the same time, you've got to make sure you've released all of the gas that you've put in with every breath. Otherwise, you get breath stacking, and that can lead to significant problems with hemodynamic instability. It can lead to something similar to a pneumothorax or actually cause a pneumothorax by increasing your intrathoracic pressures so much. I hope you found this video useful. If you have, please like and subscribe to the channel and hit the bell notification. There's going to be lots of videos coming out in the near future. And if you've got any questions about this complex topic, please post a comment in the bit below and I'll get back to you as soon as I can.